Hi, this is Sarah Alasmi, and today I'll be presenting on the use of DOACs in patients with obesity. So the objectives of this presentation is to discuss the considerations for anticoagulation therapy in patients with obesity and to analyze the available data on the use of DOACs in those patients. Also, I will be exploring the implications of the available data and provide recommendations regarding the use of DOACs. So in 2017-2018, a study showed that there is over 42% of adults in the US with obesity. And as we know, obesity is an established risk factor for atrial fibrillation, also for VTE. Those both will increase the need for anticoagulation therapy. And the options we have for anticoagulation therapy for patients with obesity include heparin, which use weight-based dosing using total body weight. We can also do low molecular weight heparin. The ACCP guidelines recommend using weight-based dosing over fixed dosing in obese patients for both prophylaxis and treatment. We can do fondaparinux, which also has weight-based labeled dosing for weights over 100 kilograms and weight limits for below 50 kilograms. And as we know, warfarin can be monitored by INR at any weight. But what about DOACs? Because of their fixed dosing and without the need for routine monitoring and limited dietary interactions, they would be a convenient anticoagulation option. But can we use them for patients with obesity? This is what the presentation will be discussing today. Although it is challenging to use PK/PD data derived from non-obese patients and apply them to those patients with obesity, I wanted to see what does the package insert say. Most of the participants who were enrolled in DOAC studies weighed less than 100 kilograms, and no dosage adjustments are provided in the package insert of any of the DOACs, despite some concerns for underdosing in patients who are overweight. So for apixaban, they mentioned lower Cmax and AUC in patients who weighed over 100 kilograms compared to 65 to 85 kilograms, whereas in rivaroxaban, there were similar AUC and Cmax for patients in those two weight groups. For dabigatran and edoxaban, they did not mention any weight-related implications on PK parameters. So the International Society of Thrombosis and Hemostasis made a statement regarding this issue in 2016, and based on the lack of clinical information and the concern for underdosing when using DOACs in obese patients, they do not support the use of DOACs in patients with BMI of more than 40 or weigh more than 120 kilograms. And they said if you do use the DOACs in those population, you should obtain a drug-specific peak and trough level. And if the level is within appropriate range, then you can continue the use of the DOAC. But if the levels fall below the expected range, change to warfarin rather than adjusting the DOAC use. However, we know that the availability of appropriate coagulation assays is limited for DOACs. Also, therapeutic ranges and clinical efficacy and safety are not really well established yet. So even if we were to get the peak and trough levels, we don't really know how this reflects clinically. But since ISTH guidelines were released in 2016, there were several studies that have been conducted to further evaluate the impact of body weight on the safety and efficacy of DOACs. And I will be discussing some of those studies today. So the first study I will be discussing today was recently published. It's a retrospective study that included 1840 adult patients with obesity who were treated for VTE with either a DOAC or warfarin in more than 40 centers between January 2011 and October 2015. The primary outcome of the study was recurrence of VTE within 12 months of the admission date. The secondary outcome included the occurrence of pulmonary embolism and deep vein thrombosis, and another secondary outcome was bleeding. It's important to mention that rivaroxaban was the most DOAC used. Over 90% of the patients who received the DOAC were getting rivaroxaban, and a smaller percentage was getting apixaban or dabigatran. They included patients that weighed between 100 kilograms to 300 kilograms, and most patients were middle-aged white men. Approximately 20% of the study cohort had a history of VTE. And what they found that there was no significant difference in the occurrence of VTE, PE, or DVT between patients treated with a DOAC versus warfarin, and no significant difference in bleeding between the two treatment groups, including warfarin and DOAC. So some of the strengths of this study include that it was multi-centered, like I mentioned earlier, and it included patients who got anticoagulation before the index visit and those who received de novo anticoagulation for an acute VTE. This gives us more information in variety of thrombotic risks. And some of the weaknesses include that it was a retrospective study, which means whether to prescribe a DOAC or warfarin was up to the provider, and we don't know what factors were considered in that decision. The study excluded patients with AFib and AFlutter. They also did not include any information about adherence and duration of treatment, and they did not include any information about the INR for the warfarin group. So we don't really know if the patients were in therapeutic range during the study. And like I mentioned, the majority of patients in the DOACs group received rivaroxaban, and we know that there are differences in the safety and efficacy of other DOACs. And a majority of the patients were white males, so we cannot generalize those results to the whole population. An important thing to mention also that it was funded by Pfizer, which can contribute to some biases. Now, the second study that I will be discussing is very similar to the first one. However, it included higher BMIs, and the patients were mostly Black and Hispanic patients. It was a single-center retrospective study, and it evaluated patients with a BMI of at least 40 or higher who newly initiated apixaban, rivaroxaban, or warfarin for treatment of VTE or atrial fibrillation. And they wanted to determine whether apixaban and rivaroxaban are as effective and safe as warfarin in more morbidly obese patients. This study was between March 1st, 2013 and March in 2017. And what they found was that there was no significant difference between the groups in terms of recurrence of VTE, incidence of stroke in patients with atrial fibrillation, or incidence of bleeding. And those findings were also applicable to patients with a BMI of 50 or higher. Some of the characteristics of this study fall under strengths and weaknesses, since it included morbidly obese patients, which is good because those patients are usually not well represented in papers, but at the same time, we cannot generalize the data for less obese patients. And again, the majority of the population was African American or Hispanics, and they did not have any adherence or INR data similar to the first study. There are many other small retrospective studies that had similar results to these two studies I mentioned. However, we don't really have a lot of prospective trials. The data we have are limited to phase 3 clinical trials, which included limited numbers of patients with extreme weights. And there are also several post hoc studies. I will be discussing in details one of them. It is the Aristotle trial. It had a post hoc analysis done, which evaluated the use of apixaban in obese patients with non-valve AFib. They divided the cohort into different groups based on BMI. Their primary efficacy outcome was stroke or systemic embolism, and their primary safety outcome was major bleeding. As you can see, the risk of an embolic event was significantly lower in apixaban compared with warfarin in two groups, the 18 to 25 and 35 to 40 BMI groups. In other groups, no significant difference was observed. However, you can see that in some of the BMI groups, the confidence interval for the hazard ratio was very wide. This means that the results of the study may not be too reliable. Also, apixaban demonstrated a lower risk of a major bleeding event compared with warfarin in the 18 to 25 and 25 to 30 BMI groups, with no significant difference in other groups. Again, the 95% confidence interval was wide in some of the groups. Finally, it's important to keep in mind the nature of post-hoc studies and how they can lead to false impressions. Now, this table is a nice summary provided by a paper which summarized multiple additional studies that looked at DOAC use. While these studies were not exclusively looking at obese patients, the table shows a subgroup analysis for obese thromboembolism patients. As you can see, the studies looked at a wide variety of DOACs. This include dabigatran, apixaban, rivaroxaban, and edoxaban, comparing them to warfarin. And overall, there was no significant difference in efficacy between the study groups in these studies. But however, not all of the studies reported safety data, but no significant difference was seen in those who did report safety data. We have few data from PK and PD studies. However, we don't really know the clinical implications of these data, and it's most likely agent-specific since some differences among DOACs have been observed. And observations of efficacy and safety are limited to subgroup analysis from phase 3 studies that had a low representation of obese patients. And these analyses demonstrated that DOACs and warfarin had no significant difference in terms of VTE prevention and bleeding risk. Some studies suggested obesity paradox, like the Aristotle study, in which overweightness and obesity were associated with reduced mortality, stroke risk, and bleeding risk compared to normal weight. However, there is no current evidence of an obesity paradox in the VTE population. That is why investigation of the obesity paradox would help with the decision-making regarding the use of DOACs. Now, in conclusion, even though the overall consensus of the studies available regarding the use of DOACs in patients with obesity is reassuring, a prospective randomized control trial is needed to make a well-informed clinical decision. And based on the quality of the available data, I recommend following ISTH recommendations and reserve the use of DOACs in patients with obesity to situations where warfarin use is contraindicated. And since there are no dose adjustment recommendations regarding DOACs use in obesity, it is necessary to be cautious until additional data become available. Finally, should you use a DOAC in patient with obesity, rivaroxaban is the only one that showed no difference in both kinetics and treatment outcomes, whereas other DOACs, we either don't have PK data on them or they showed differences in the PK parameters compared to normal weight patients. Now, this is the end of my presentation for today. If you have any questions, please feel free to email me and let me know if you have any suggestions. I would really appreciate your feedback. And these are my references. Thank you for watching.